Thank you, and good afternoon, Chairwoman Velasquez and members of the committee. I'm Dave Tayloe, Jr., President of the American Academy of Pediatrics. I've been a pediatrician in rural private practice where the cash flow of the practice is two-thirds Medicaid and S-CHIP in Goldsboro, North Carolina for over 32 years. I appreciate this opportunity to testify today before you regarding the impact of the novel influenza A H1N1 virus on American small businesses. On August 24th, the President's Council of Advisors on Science and Technology estimated that the novel H1N1 flu strain could result in the hospitalization of up to 1.8 million people and cause as many as 90,000 deaths, a number that is roughly double the death toll from a normal flu season. If these projections prove accurate, this flu epidemic will tax every aspect of our nation's healthcare system, emergency departments and hospital wards to private practices and public health departments. Of special concern to the American Academy of Pediatrics is the fact that this flu strain is impacting children disproportionately. Based on infection rates to date, the Centers for Disease Control and Prevention calculates that infection risk in the 0 to 24 age group is 4 to 5 times greater than for those in the 25 to 49 age group and 20 times greater than for those over age 65. If the virus sickens half of U.S. children this season, the number of ill children would exceed 37 million. Infection rates could ultimately be even higher. The President's Council of Advisors on Science and Technology warned that of the 30,000 to 90,000 deaths anticipated, most would be concentrated among children and young adults, and we're already seeing that in our state. Pediatric medical practices and other medical providers who serve children face a special challenge from the H1N1 virus. The AAP anticipates that our membership will face a double whammy of business interruption due to staff absence and illness combined with much higher workloads from sick children and families seeking vaccination. Over 95% of office-based pediatricians practice in settings defined as small businesses. Many practices operate with very small staffs, meaning that one absent nurse or receptionist can all but cripple the office's ability to function. Most small pediatric practices are already facing serious challenges in remaining financially viable due to the economic downturn and employers' quest to decrease health insurance expenses. AAP membership report that practices have seen increases in families with Medicaid, high deductible plans, or no insurance. Also, the payment differential between private pay and Medicaid is so severe that there are significant downstream impacts on pediatric practices' ability to keep their doors open. For example, Medicaid and most private insurers pay approximately $20 for vaccination administration of adults. State Medicaid program payment to pediatricians ranges from $2 to $17.85 for the same service, with 38 states paying less than $10 for vaccine administration. Nationwide, Medicaid pays an average of 72% of what Medicare pays for the same services and only 64% of average commercial payment. We are the public health infrastructure for this problem. We understand the vaccine is coming from the federal government to the states, to the health departments, and then our office has a contract with the health department to deliver the vaccine. The Academy has a real ethical dilemma. Do we ask our members to fully participate in a program that's going to cause them to take business losses because of the poor Medicaid reimbursement that hasn't been fixed since 1965? So this crisis in public health is shining a bright light on the problem with the state's failure to pay adequately for physicians to participate in Medicaid. As a result, more Medicaid patients are seen by a pediatrician, the greater the financial challenge to the practice of the small business. And Medicaid's under severe financial stress in the states as well with decreased tax revenue. So we've seen cuts in the Medicaid payment rates. We took a 3% cut this year and we'll take a 3% cut next year in North Carolina. From a clinical perspective, pediatric practices must also plan for greater workloads. The Academy and the CDC recommend all children ages 6 months to 18 years receive the seasonal influenza vaccine, adding 30 million children who need to be vaccinated for seasonal flu only. Then because the H1N1 strain is different, it's going to be a separate vaccine. Children have virtually no immunity, and we anticipate the CDC will instruct us, the pediatricians, to give each child 2 doses of H1N1. So that's 3 office visits for each child. Parents may therefore need to make all these trips, taking time off work, to cover seasonal flu and the H1N1. The AAP encourages vaccination of children in the medical home, and pediatricians want to do whatever they can. And we recognize that schools and other non-traditional locations may be utilized as vaccination sites in some states. Children, and particularly those who are 6 months to 5 years, still need access to H1N1 influenza vaccine through their medical home. Yes.